all I'm asking for is 50 minutes, okay?
I think I was extending the slides.
Pardon?
So they're sending the slides.
Yeah.
If I use my phone and take you information about what your teachers are about.
Yes, I want you to focus. I don't want you guys to be ignored in the discussion. You can always view. The World Wide Web is free for you to access after 11. Right, but we're going to try to get as patient as possible because I'm starting 5 minutes late. These are the objectives. We're looking to stay in this and that adrenal glands, recall the hormones produced by there, state the physiology behind the production, including the feedback loops, which we introduced into last week, though it had to do with not just the adrenals but other endocrine organs. Determine the symptoms of adrenal disease based on the hormones that are either in excess or deficit. The state of biochemical and imaging tests that we use to diagnose. And at last, we look at management, okay? Of the common diseases. So we're going to try to be as basic as possible. And this diagnosis is going to substitute for your anatomy class. We have weighs about 4 to 5 grams each gland, and they're divided into the cortex, which is the bulk of the gland, accounting for 90% of the weight, and the medulla, which is on the inside and accounts for about 10%. The gland, of course, has to have an arterial supply, right? And it gets blood flow from the renal arteries, the aorta, as well as the inferior phrenic arteries. And you can explore that in your anatomy class in further depth. It also has to have venous drainage, right? And this goes from the adrenal veins into the inferior vena cava. So this is what the cross-section of the adrenal gland looks like. So as you know, the adrenal is also called the suprarenal glands. So that tells you that this is on top of the kidneys, right? Renal for kidneys, super above. So both glands lie on top of the kidneys. So you have a right and a left adrenal gland. And if you were to slice the adrenal gland cross-section over here, and this is what it would look like. You have the cortex, which is the coating or the outside portion of the gland, and you have the inside portion. And the cortex is further divided into 3 layers. And for ease, you know about GFR for kidneys, glomerular filtration rates. We use the same acronym for GFR from outside to inside. That's just one way to remember it. So you have the zona glomerulosa on the outside, right? Zona fasciculata sandwiched in between the glomerulosa and the reticularis, and on the very inside, almost like the donut, the jelly part of the donut is in the middle. A little more detail here. So again, same cross section, just a little prettier. The zona glomerulosa to the very outside. On the inside, in the sandwich, this is the ham part or the cheese, depending on whether you're non-vegetarian or vegetarian. Fasciculata, and then the reticularis is the inside piece of bread, and then you have the medulla in the middle. And the glomerulosa produces the mineralocorticoids, the fasciculata, the glucocorticoids, and the reticularis, the androgen. Another way of remembering or working, you guys already know the mnemonic. And on the very, very inside, you have the catecholamines and the peptides. Salt, sweet, sex. Okay? That's how we try to have you remember what is produced by there. So the salt is on the outside. Remember, mineral corticoids are important for salt metabolism. Okay? And then the glucocorticoids, they promote hyperglycemia, so they can cause a sweetness. And then the sex hormones or the sex steroids. So from moving from outside to inside, GFR, just like the kidneys, and salt sex, so you know exactly what is made where. Okay? And this we're going to look at in a little bit more detail. It's not so small, very to figure out, but the liver makes angiotensin, which is converted by renin to angiotensin 1. And then from the lungs, we know that ACE is produced by the lungs, right? And ACE converts angiotensin 1 to 2. And then we speak about the functions of angiotensin 2 and aldosterone in a moment. This is a little small, but just to give you an idea, that's what the red angiotensin aldosterone system speaks pituitary gland and its function, and we spoke about excess function and reduced function. The same thing applies to the adrenal gland. The same thing applies to any of the end organs that we speak about in endocrinology. So today we're focusing on just one of those end organs, which we mentioned a little bit about last week when we spoke about the feedback loop, the ACTH and so on. Today we're looking at the adrenal gland in its entirety. And the first is the salt hormone, the mineral corticoid, which is made by which of the layers. Glomerulus. Alright, so if we have pathology in the adrenal gland at the level of the zona glomerulosa, which makes mineral corticoids, and we have that pathology, a nodule or hyperplasia causing excess production of mineral corticoids, excess of this salty thing. What are some things that you think might happen? So your body is retaining sodium, it's eliminating potassium. So with this sodium retention, what might happen? Hypertension. And what about? Well, hypertension tends not to occur, but the hypokalemia would. So the patients are hypertensive, they have elevated blood pressure, and they lose potassium. But remember, not everybody with excess mineral corticoid production will have hypokalemia. And that is one of the reasons we have missed a lot of people. Well, in the past, we have what we call primary hyperaldosteronism. So that's a condition that will occur if you need too much mineral corticoid or aldosterone. It's hyperaldosteronism, right? Yes, the people that have hypertension, but because we were of the impression that everybody with this condition should have a low potassium, we did not really have a high index of suspicion and we didn't test as many people as we should. And now we recognize that primary hyperaldosteronism is actually present in up to 10% of people with hypertension. So now we know that not everybody, only about 60% of people who have this condition will have a low potassium. So we no longer wait to see a low potassium in specific individuals. And we're going to tell you which people with hypertension need to be tested for this condition, okay? Those with hypokalemia is one.
What percentage of people have hypertension?
About 60%. About 60% of individuals may not have it. So you have about a third of people with it. Okay, but you have, depending on your source, you will have different percentages. But we mentioned that to say, we don't wait to see a low potassium to think that individuals may have it. And we will tell you which persons, in which individuals we need to consider this as a cause of hypertension. Remember, hypertension, yes, essential hypertension exists, but you also have something we call secondary hypertension, in which case you need to make sure there are no hormonal components that are contributing to it, but we'll get to that shortly. So, because we're talking about adrenal disease, get to the
So are we saying that we're looking at the sodium levels during the investigation itself?
So the sodium levels are usually, the patient is usually eunatremic, so the sodium is not really a good indicator, unless the patient has other reasons for hypernatremia. But the potassium, there's significant sensitivity to potassium, more sensitivity to calories than retention of sodium, so the patients will lose a lot of potassium and hold on to high normal is what the sodium usually is. It tends not to be in the hypernatremic range.
You're saying 60% are low potassium?
We're going to get to that shortly. Up to 2/3 of individuals will have normal potassium. Okay? A third of them will have a low potassium, but those numbers it depends on the study you're looking at. So these studies are done globally, depending on the population. Admittedly, we don't have local figures. Really, a lot of the research that we do in Jamaica is really at university hospital. We don't really have a lot of transnational research. And when we do that, we look more at the prevalence of hypertension and not necessarily at secondary hypertension. Very often it's resource availability. So if you've ever heard about the Jamaican Health and Lifestyle Survey, It does look at a national prevalence of hypertension, but it does not go into secondary causes. Because for that, you would have to not just say, yes, these individuals have hypertension, but you have to go and check their blood tests and to see whose potassium is normal or high or low, and then look at the medications they're on. Because remember, there are some medications which are cause potassium loss, right? Diuretics, for instance, and those may actually compound. So it's not an easy study to do per se, but of the individuals who have primary hyperaldosteronism, you're not going to find 100% of individuals with a low potassium. Even though we know excess aldosterone will cause calciusis, if you don't see a low potassium, it does not mean the patient does not have the condition. That's essentially what that, separate and apart from the actual exact figures, because we're not going to tie it down and say if you don't say 60% or 40%, you're incorrect. What we want you to appreciate is that not everybody with the condition is going to have a low potassium. That's the essence of that point there. Not necessarily tying it down to a specific number, which varies depending on the study you're looking at. Alright, so as I mentioned, so hypertension plus or minus, and that's why we have the plus or minus low potassium. And remember, we can have excess aldosterone production from non-adrenal sources. Because we mentioned to you that renin, which is made in the juxtaglomerular apparatus in the kidneys, will stimulate the production of angiotensin 1 from angiotensinogen. You're looking at the flow chart here. But the bottom line is that this flow will end up with excess aldosterone. So you can have an individual, and this is the case we're speaking of today, where you have an adenoma or a lesion in the adrenal glands, zona glomerulosa, that makes a lot of aldosterone, right? But you can also have a lesion in the kidney that is called a reninoma that makes a lot of renin, and because you have so much renin, it's stimulating a lot of conversion all the way down to elevating aldosterone. So how are you going to know which is which? So the patient comes in with a high aldosterone, you want to know if it's from the kidneys or it's from the adrenal. How will you differentiate? So both of them have elevated aldosterone, right? How is the renin going to evolve? So if the patient has a problem in the kidneys and it's a reninoma, you expect renin levels to be high, right? And that is what's driving the aldosterone production. But remember the negative feedback thing that we discussed last week, if the problem exists in the adrenal gland and that is where the aldosterone excess is coming from, then what do you expect to happen with renin? It will decrease because you have aldosterone overload and it's sending a feedback signal to the kidneys. It's saying, shut down any further renin stimulation, I don't want to have to make anymore. So that is how you distinguish. And when we speak about investigations, you see why we have to do aldosterone and renin to be able to figure out where the aldosterone is coming from. It's coming from the adrenal glands, you expect the renin to be suppressed. It's coming from the kidneys, you expect the renin to be elevated. Alright, so we don't do aldosterone in isolation. So I skipped that just to explain that concept. So the most common cause of aldosterone excess is really what we call Hunt syndrome. And we've now moved away in medicine generally from using apostrophe S, and you guys can go and read why when we describe syndrome. So okay, so it's no longer Hunt's syndrome, it's no longer Cushing's syndrome. We leave it at the last name, we eliminate the apostrophe altogether. Okay, you can read why. But the patients, in addition to having a single adenoma where they have a mass in one side, they could actually also have bilateral hyperplasia. And you coming from histology, you know the difference between hypertrophy and hyperplasia, right? I don't think we need to get back there. So it could be that bilaterally the adrenal glands are hyperplastic, okay? So the pathology is not just on one side with an adenoma and a screen lesion, but it's both sides that are pathologic. And finally, the least excess renin levels in an autonomous fashion. Because you have a lot of renin, it's going to convert angiotensinogen to angiotensin. You have a lot of angiotensin, lots of ACE, and it converts all the way down to having a lot of aldosterone in the system.
Okay, so for example, you have increased renin and aldosterone.
Yes.
And
And for the hypoaldosteronism due to an adrenal cause,
you have increased aldosterone and renin.
yes, that's right. Decrease. Alright, so think about it. Lots of Jamaicans have hypertension or prehypertension. From my recollection, I think about 2/3 of us between 15 and 74 have either hypertension or prehypertension. But 1 in 10 of individuals with hypertension have undiagnosed or have primary aldosteronism, and a lot of those are undiagnosed. Think about yourself when you're a GP sitting down in your office. Somebody comes into you for elevated blood pressure, you put them on an antihypertensive. If that's not working, you increase it or you add a second or a third. But many physicians are not inclined to think that this might be a secondary cause of hypertension. And we'll speak about the persons in whom you need to think this and test accordingly. It is also the most common cause of secondary hypertension, okay? And the reason it's important to diagnose it, okay, is that it causes several complications which are exacerbated beyond the individual who has primary hypertension, okay? Somebody comes in, regular hypertension, yes, they may develop left ventricular hypertrophy, they may develop coronary artery disease, stroke, and chronic kidney disease, but it's much more severe in individuals in whom the cause of hypertension is primary hypoaldosteronism. So you want to catch them and treat accordingly to try to prevent these complications, which are significantly more exacerbated than those with primary. So in whom should you suspect primary hypoaldosteronism? People who have resistant hypertension, okay, and the definition is right there. You have somebody in your office with hypertension who is on 3 antihypertensive agents and they're not controlled. A lot of Jamaicans fall into this category. Or if you're controlled, but it takes 4 agents to do so. In those individuals, you have to screen for primary hypoaldosteronism because we know it's common. We know it's out there, it's 1 in 10 persons with hypertension, and it's the most common cause of secondary hypertension. People who have hypertension with hypokalemia, we did say that potassium, low potassium does not always have to be there, but if it's there and the patient has hypertension, you have to screen for this condition. Okay? This is so even in an individual who has hypertension and is on a medication which you know can cause low potassium. So don't blame the diuretic for the hypokalemia, whether the patient is on a diuretic or not. They have hypertension and low potassium, they should be screened for primary hypoaldosteronism. If they're diagnosed with hypertension in the young, somebody who's in their 30s, in their 20s, with hypertension, you have to screen them for primary hypoaldosteronism. You have a question?
I don't want to get too far, but you were mentioning about diuretic, you mentioned about you want
Potassium.
potassium.
There,
You want to
right.
have that aldosterone. So let's say
Right. So we're going to speak about, when we talk about treatment, we'll touch on exactly your points, okay? But there are different diuretics. There's some which may cause hypokalemia and some which may cause potassium retention. And there are diuretics which are mineral corticoid receptor antagonists, which are the ones we're speaking about, and which we will touch on very shortly. If the patient develops pain suggestive of an appendicitis, for instance, they come in with pain, it's radiating to the iliac fossa, you do a CAT scan, so you're looking at that for appendix, right? But incidentally, you weren't trying to figure out what's going on with the adrenal because the patient's symptoms are totally unrelated, but you scan them and the radiologist sends out the report and says, yes, appendicitis is there, but I also see a lump in the adrenal. That's what we call an incidental lobe. So it's incidentally found, it's an adrenal incidental lobe. You have to screen to see if it's active and it's making excess aldosterone. Okay? Somebody who has a first-degree relative who has primary hypoaldosteronism and hypertension, people who have hypertension early onset. So you're diagnosed at 42, your mother diagnosed at 30, your sister diagnosed at 28. Low age or a young age of diagnosis of hypertension or a young age of stroke diagnosis, PA should always be investigated. Or, and of course, individuals, there is a link between sleep apnea and primary hyperaldosteronism. There's thought to do what we call a bidirectional association. The pathophysiology behind it not fully worked out, but in individuals with hypertension and sleep apnea, sleep as well. So, biochemistry, and we've spoken about this before. So, how we would test. So, we already stated why you would test and which individuals you suspected it. But now you have to know what type of tests are you going to do. So, you send the patients for what are the tests? And it's on the slide. Why do you want to check calcium levels?
Because even though he wants to pick up whether it's hyperkalemia.
You sure it's calcium you want to? Potassium. Yes, potassium definitely should be checked. Hypokalemia can cause a suppression of aldosterone levels, right? So when you're checking your primary aldosteronism, you want to do your plasma aldosterone concentration. First one, you want to do your plasma renin activity, second one, and we expect what to be the case for the PAC. Aldosterone. The aldosterone? Increase aldosterone, and what you expect for the renin activity? Decrease. And so we do a ratio of PAC to PRA. Plasma aldosterone concentration is elevated, plasma renin activity is low, so that ratio will be elevated, right? And we typically say more than 20, but it depends on whether you're supine or erect and so on and so forth. But what you need to recognize is that aldosterone is elevated, renin low, and the ratio is high. And while we're checking for potassium, it may or may not be low, but in an individual with hypokalemia, you always want to make sure you treat that first. Get the potassium up to normal with potassium supplementation, because a hypokalemia is going to cause a suppression of your aldosterone and may cause a false negative. So you're going to see a low aldosterone and a low ratio, and you're like, oh, this patient doesn't have primary hyperaldosteronism. You always need to make sure you get that potassium normal first before you test the patient. And of course, there are some confirmatory tests that we want to do, which is like the dynamic component, and we won't get too much into that.
On the previous slide,
Yeah.
what does PA stand for?
Primary aldosteronism. Some people call it primary hyperaldosteronism, some call it primary aldosteronism. Yes. And what is what? Family history.
Okay, and so primary aldosteronism is just when the increase in aldosterone is due to some abnormal tissue in the body.
Yes, so it's either going to be hyperplastic, as I said before, or it's going to be adenomatous, which is a discrete lesion. So it's either all of the glands hyperplastic, both of the glands hyperplastic, or you have a discrete lesion that's making too much aldosterone.
Excuse me, it's going back to the other side.
Other side, I said the one before, the one after.
The one after. Have they ever considered doing like a aldosterone concentration and a calcium ratio?
Why can't we keep talking about
No, that's calcium, sorry.
Calcium is in your
We
brain.
just learned calcium a
We
while
just
ago.
learned
Oh,
I'm sorry for that.
No, no.
The ratio between the potassium levels and the aldosterone.
If you were to do that, recall that we mentioned some people are non-anemic, so you use some individuals if you were to do that. It's not everybody has a low potassium.
Understood, but what if for those individuals who you're treating, so like for example, you treat individual for the hypokalemia,
So you get to treat the potassium up to normal.
up to normal, could you use the ratio then between the aldosterone concentration and the calcium to up to like monitor if
To monitor or to make a diagnosis.
to make the diagnosis?
Issue with say it's a renin secretion, because you always want to take into consideration your renin activity to make a determination whether it's renal in origin or adrenal in origin. So if you're eliminating the renin from the picture altogether, then you won't be able to make that distinction.
It wouldn't be eliminating the renin. You'd have the renin.
We haven't devised anything like that in endocrinology yet, aldosterone and potassium.
So, starting with aldosterone,
Yeah.
what is only per se like adrenal because it's the remedy, it's something, there's a remedy
And it's not called primary. So primary disease means it originates in the organ of in question. Primary is an adrenal pathology, as opposed to something external, where you would typically call it secondary. So if it's further upstream in the axis, it's no longer considered primary. Primary is just of the end organ. So if it starts in the thyroid, we call it primary thyroid disease. Adrenal, primary adrenal disease, testes, primary gonads, and so on.
So if it's in the kidney, it's
Secondary.
So if it's in the kidney, secondary, yes. Or you would specifically say it's already normal. You would call it by what it is. So you can know how to manage. So how do we treat patients with primary aldosteronism or primary hyperaldosteronism? Surgical management is typically the cure. We don't have any medical treatment for curing primary hyperaldosteronism. Okay? So you've done great investigations, you've made the diagnosis, you send the patients to get the CT scan of the adrenals, and it comes back showing that there's an adenoma, then you want to remove it. And nowadays we use laparoscopic surgery, so you don't have to make a big cut in the abdomen. Use the little tubes and you remove it, and the patient should really be cured, ideally. But there's some people who've been hypertensive for so long that there is vascular remodeling, and even if you remove the adrenal problem, then they have developed long-term hypertension. The blood vessels have really gone through a lot of changes, which would not necessarily be reversible. But what you'll find for most patients is that the number of antihypertensives that are required comes down. So if you were on 4 before, now you can be managed on 1 or 2 at lower dose taxol. So not everybody is cured. Would be cured if we pick them up earlier. But if it's left for too long, with vascular changes which are chronic, then the hypertension very often is not cured. But what individuals will find much easier to manage is the hypokalemia. If they have hypokalemia, typically that resolves with removal of the lesion. If the patient doesn't want any surgery, or they're not a surgical candidate, or they have bilateral disease like hyperplastic disease, you do the CT scan and there's nothing there, then we tend to go for medical management. Okay? So we give them the same diuretics that you mentioned, the potassium sparing ones, in form of spironolactone or eplerenone. These are mineralocorticoid receptor antagonists. So they block the receptors, so the aldosterone cannot stimulate the receptors for sodium retention and potassium excretion. So again, the potassium usually resolves low potassium, and the hypertension is better controlled with these individuals. Okay? But these agents are reserved for those who you're not going to offer surgery for whatever reason I saw here. Alright, so we're moving on quickly because we're halfway in. And I know we're accustomed to seeing Cushing syndrome. So it's adrenal Cushing syndrome. And we spoke about Cushing last week. Cushing syndrome is a condition where you have chronic excess glucocorticoid production, and which layer is glucocorticoid made?
Vesicular.
Which one?
Vesicular.
Vesicular. Right. So it's the F, which is the sandwich part. Of course, Cushing syndrome can be ACTH dependent, whereas we spoke about last week, you have something in the pituitary gland that's making a lot of ACTH, and the ACTH is going to stimulate the adrenal cortex to make excess cortisol, right? But in this scenario, this is not the case. The problem is not in the pituitary, the problem is in the adrenal gland. So in that zona fasciculata, you have an adenoma, which is making excess what? are larger are the ones that are more likely to be carcinomatous. So the carcinomas are the ones typically, but of course they have to start somewhere, right? So the size of a carcinoma can be anything, but if you recognize the size is more than 6, your inclination is to think that this is perhaps carcinomatous or has a tendency to, and certainly these will need to be removed. Irrespective if Cushing syndrome, it needs to be taken out, but with significant urgency, the larger they are because of the malignant potential. But Cushing syndrome from adrenal origin can again, just like we mentioned, PA can be hyperplasia, or it could be from an adenoma. Here we could have a nodule again, which is a discrete lesion, or we could have bilateral, either micro or macronodular hyperplasia. So the same thing exists. It could either be from one area where you find a lump, or it could be both sides that are hyperplastic. Okay?
Quick question is, when you say a discrete lesion, you mean like well circumscribed?
Like an adenoma, yes, that you can pick up on a CAT scan. So you do a CAT scan and it says, I see an adenoma, it is 3 centimeters by 2 centimeters by 5 centimeters. So you can put dimensions on it. You do the same CAT scan, nothing is seen, and because remember from hyperplasia you need the histology, right? But this hyperplasia, when you look at it in the pathology department, can either be micro or macronodular. But whatever it is, it can either be a discrete lesion or it could be hyperplastic. And that's going to inform how you decide to treat the patient as well. But for you to say that this excess cortisol, and again the same concept, that's why I said endocrinology is the best and easiest understood subspecialty in medicine. Once you work it out, so the same thing exists here. You have a lot of cortisol, right? And you're going to now look at your ACTH to decide on whether you think that Cushing syndrome is coming from the adrenal or is coming from the pituitary. If it's pituitary, cortisol is high.